This next section talks about infections of the respiratory system, digestive system, and genitourinary system. We'll begin by talking about the respiratory diseases caused by microorganisms, including rhinitis, pharyngitis, diphtheria, whooping cough, influenza, tuberculosis, pneumonia, and parvo. So rhinitis, or the common cold, is caused by the rhinovirus, and this is a picture of the rhinovirus. Symptoms include sneezing, scratchy throat, runny nose, so typical symptoms when you guys get a cold. Everybody in here has probably had a cold before. Symptoms begin 2 to 3 days after infection, generally not accompanied by fever, and you just give supportive care. There are no drugs that are going to be effective against the common cold. The common cold, in addition to being caused by the rhinovirus, can be caused by over 200 different viruses. 99 serotypes, so technically you could get the common cold about 99 times in your lifetime. Transmission by respiratory droplets, and other virus types include the coronaviruses and adenoviruses. And then here's a little table for you to review the common cold. So a question on the exam that you may see about this, because there's a lot of respiratory diseases that talk about the common cold symptoms, I would probably just ask, what is the causative agent of the common cold? And to that, you would answer the rhinovirus. Strep throat, also known as streptococcal pharyngitis. So strep throat is caused by group A Streptococcus, which is called Streptococcus pyogenes. So there are different groups of Streptococcus, so group A, group B, strep, so group A strep is going to be strep pyogenes. With strep pyogenes, you kind of know it's strep throat because the patient has sick breath, so their mouth smells like death, because bacteria, the metabolites, or the byproducts of the metabolism of the bacteria, tend to not smell great. So you have inflammation of the throat, red mucosa with swollen tonsils. Sometimes there's white packets of inflammatory products that you can see on the tonsils. So looking at this picture in the back, this is the uvula, and then here are where the tonsils are. So you're going to see these white patches on the tonsils. And if the patient does not have tonsils, you're still going to be able to see some white patches on the tissue that used to be the tonsils. Mucous membranes may swell, affecting speech and swallowing, often results in foul-smelling breath, and the incubation period is 2 to 5 days. So this is a Lancefield Group A strep. Again, this is beta hemolytic, so on blood agar you'd be able to see straight through the agar, and here you can see what I'm talking about there. Bacitracin susceptible, and those are all just diagnostic keys. In order to identify the bacteria, you can do that in a throat culture, and then there's also those rapid strep tests available and the latex agglutination to detect antigens on the surface of the microorganism. So this is what a positive result would look like, where it agglutinated and it's positive for strep pyogenes. And then this would be a negative reaction down here. Beta-lactam antibiotics are used in order to treat this infection. Now with strep throat, we used to just get our strep throat, and then the strep would go away after we take our antibiotics. But nowadays, this strep has the capability of spreading to other parts of the body, and getting strep throat is now a pretty dangerous thing. So if you test positive for strep throat, it's almost on the verge of being quarantinable, where you have to take certain antibiotics for a certain period of time under supervision. And the reason for that is this strep pyogenes is now starting to spread to other parts of the body pretty quickly. It can actually burrow through the back of your throat and infect your cerebrospinal fluid. It can get into circulation and cause sepsis. It can get to the underside of the heart valves and cause endocarditis. So it's disseminating from the point of infection now. So strep is becoming pretty dangerous. Diphtheria. So diphtheria is covered under the Tdap or DTaP vaccine. The D in there is for diphtheria. And I'm sure you've heard of the vaccine, the Tdap or DTaP, and you may have heard of diphtheria, but you may not really know what it is. So diphtheria is caused by the bacterium Corynebacterium diphtheriae. It's transmitted by respiratory droplets and fomites. So fomites, if you remember, that's when particles are left on an inanimate surface, and then someone comes along and touches that contaminated inanimate surface and ends up getting the infection that way. Symptoms include sore throat, lack of appetite, and fever, leading to the formation of a thick membrane in the back of the throat that could block respiration. So looking in the back of the throat, here is what that thick membrane looks like. And it can actually grow over the entire back of the throat and prevent the person from being able to breathe. If you try to scrape off that thick membrane that forms, you'll actually scrape off the underlying tissue. So it's all raw and bloody back there, and you can cause a lot of damage trying to dislodge that membrane. In addition, Corynebacterium diphtheriae produces toxins, and these toxins are very virulent, so they can make someone really sick. So antitoxin therapy is considered in some cases, but also antibiotics. So antitoxin, again, therapy and antibiotics for treatment. Myocarditis can result, so that's inflammation of the muscle tissue of the heart. The Tdap vaccine and DTaP is effective in preventing this, but the toxin accumulation can lead to heart failure, so it's important to diagnose the infection and go from there. If you look at this under the microscope, this is what it looks like, and they sometimes refer to this as Chinese letters. It's not a really good representative picture in this picture, but sometimes you'll see them stacked together and they kind of look like Chinese letters. So that's one of the diagnostic features of Corynebacterium, is the Chinese letters formation. Whooping cough. So whooping cough is also called pertussis, and it's caused by the bacterium Bordetella pertussis. This is also protected under the Tdap vaccine or DTaP vaccine, but pertussis is transmitted by droplet contact. Pathogenesis, you can start with a localized infection, but then you have a toxin that's produced which damages cilia. So the various stages, you start off with the catarrhal stage. And the catarrhal stage happens from 3 to 21 days after you've been exposed. So there's an incubation period of 3 to 21 days where you're asymptomatic. Then the bacteria in the respiratory tract cause what appear to be cold-like symptoms. So looks like you got the common cold. And that lasts 1 to 2 weeks. During that time period, this bacterium is producing a toxin which is damaging the cilia. And if you remember from previous classes what cilia do, especially in the respiratory tract, cilia are those hair-like projections on the surface of cells that are going to brush debris and brush substances out of the respiratory tract. Well, now you're damaging those structures. So once those are all damaged, you enter into the proximal stage. In the proximal stage, you have severe and uncontrollable coughing. The violent coughing spasms can result in burst blood vessels in the eyes or even vomiting. Complete recovery requires weeks or even months. By the time you get to this stage, the bacteria is likely gone. So once you get to the proximal stage, there's really no bacteria there anymore. But what happened was the bacteria that were there before you got to this stage have damaged all the cilia. So it takes weeks and weeks and weeks for you to be able to repair the cilia to brush the debris out of the lungs. But with damaged cilia, the debris stays in the lungs, and then you get a lot of that urge to cough and excessive coughing, which again results in vomiting in most cases. Treatment is supportive care. Antibiotics can prevent the spread of the disease, but once the person has reached that proximal stage where you really know what it is, it's pointless to give them antibiotics because the bacteria is likely gone or the numbers have diminished to below an infectious threshold that it doesn't pose a threat to the current patient. It's just preventing it from spreading to the next person is the goal of antibiotic therapy. The flu. So influenza or the flu begins in the upper respiratory tract. Serious cases may also affect the lower respiratory tract. The flu has a 1 to 2 day incubation period, 1 to 4 day incubation period. Symptoms begin very quickly with headache, chills, dry cough, body aches, fever, stuffy nose, and sore throat. Since a lot of these respiratory diseases talk about having like cold-like symptoms, the one to look for with the flu is the body aches. So you just ache all over your body. That's kind of the key to look for in an exam question. Extreme fatigue can last a few days or a few weeks. So the influenza virus is a zoonotic virus, which means that it can be transmitted between multiple species. There's three main viruses, influenza A, B, and C. The one that we get vaccinated against is usually influenza A. Birds are common reservoirs, and if you think about it, birds are flying through the air and we're coughing up into the air. So the virus that we're coughing up is getting into the bird, and then it's mutating inside of the bird, and it can infect the bird and the person, and then the bird poops and the virus lands back on the people, and it's a continuous cycle. The hemagglutinin and neuraminidase groups, which I talked about when we went through viruses, that's how we name these viruses. So it's dependent on the number of hemagglutinin and the number of neuraminidase. So if we have hemagglutinin 1 and neuraminidase 1, then we have H1N1, and that is the swine flu. So that's how we name these viruses. Treatment includes amantadine, which blocks replication, Valenza and Tamiflu blocks neuraminidase, and then there's new treatments that are coming out because viruses are developing resistance against the existing treatments. These treatments are usually reserved for the critically ill patients or patients that have only had symptoms for less than 48 hours. After 48 hours of symptoms, you're going to live out the course of the infection no matter what. Even with treatment, you would just live out the course of the infection. So after 48 hours of having these symptoms, they usually don't give that treatment anymore. But in the critically ill, then the time frame doesn't matter so much. Vaccination, so there's different vaccines that exist. They had a flu mist, they took it off the market, they put it back on, so these vaccine preps are constantly changing. But there is a new trivalent vaccine each season, so they kind of make an educated guess of what the most commonly circulating strain of the flu is going to be next year, and they'll develop a vaccine that targets those types of flu viruses. And that's what they'll vaccinate everyone with. The next one is tuberculosis. So tuberculosis is caused by Mycobacterium tuberculosis. There's also Mycobacterium avis, which is kind of more associated with the birds, but people can definitely get this form of tuberculosis as well. Only about 5% of infected people actually develop a clinical case of TB, but untreated TB progresses slowly. Clinical TB is divided into primary, secondary, and disseminated tuberculosis. So a little bit of background on the microorganism itself. So Mycobacterium tuberculosis is an acid-fast positive bacterium, and what that means is it contains mycolic acid in its cell wall. Mycolic acid is a wax-like substance that makes these microorganisms pretty resistant to antibiotics. So the only way to penetrate through the cell in order to treat them with the antibiotic is to wait for these cells to actually go through cell division. While they're dividing, that membrane becomes, and the cell wall becomes really thin, and the antibiotics can then penetrate. These, unfortunately, have a really long replication time. So their generation time is a couple days to sometimes a couple weeks. So they don't replicate like E. coli does every 20 minutes or so. It takes them a really long time to replicate. So in order to properly treat a patient that has a tuberculosis infection, you need to give them a long course of antibiotics. Tuberculosis is transmitted by droplets. It's not easily killed by phagocytes. So when phagocytic cells eat Mycobacterium tuberculosis, usually the bacterium can survive inside of the macrophage. So primary tuberculosis is usually asymptomatic. The only way that a person would know that they have primary tuberculosis is if they go get a TB skin test. In the TB skin test, they're going to inject a small amount of purified protein derivative, or PPD, from tuberculosis. If the patient has been exposed to tuberculosis in the past, then they would have a positive TB skin test. The T cells in the area perform a type 4 hypersensitivity response, and you would see a raised bump and it would change color, and then you know that they've been exposed. So with a positive TB test, then you would follow that up with a sputum culture, antigen-specific tests, or a chest x-ray. So when you get to secondary TB, it's pretty obvious with the signs and symptoms from the patient that they have tuberculosis. So this is when the real symptoms begin. Fever, coughing, green or bloody sputum, which is just a deep spit, anorexia, weight loss, fatigue, night sweats, and chest pain. This disease was formerly called consumption. If anyone's watched that movie Moulin Rouge, the main character in that movie had tuberculosis, and the whole movie she was like coughing up blood, and then if you saw it, you know the ending from that. But they used to call it consumption because they thought that they were being consumed from the inside out. They'd cough up blood, they'd get pale, and they would die. It's another reason why they called it the white plague, because of the pale color that people would take on when they had tuberculosis. So we've talked about TB quite a bit throughout the semester. We talked about it with the mycolic acid and the acid fast stain. We talked about it again when we went through streptomycin, so hopefully everybody got a chance to watch the video on the white plague and streptomycin. And now we're talking about it again, so this is for sure going to be on the exam. Extrapulmonary tuberculosis is when the tuberculosis leaves the lungs and starts to infect other organs, and the complications from that are always fatal. Today, tuberculosis is still the #1 bacterial-related cause of death worldwide. Not necessarily in the United States, but in a global level, tuberculosis kills the most people out of any other bacterium in the world. So this just shows the TB skin test, and you can see how you inject in the PPD, and a type 4 hypersensitivity response would happen if the T cells have been primed for exposure to tuberculosis, and you would see the color change and the raise of the bump. So after a positive TB skin test, you want to follow that up with a chest x-ray to see if there really is an active area of infection. And here you can see a positive chest x-ray and the area of infection. You can also do an acid fast stain of the sputum. So here's a sputum sample. The pink rods would be positive for tuberculosis. Vaccine adjuvants may give false positives for the TB skin test. So if they've been vaccinated against tuberculosis or closely related anything, then they may give a false positive result, which is why you always want to follow up a positive skin test with looking at the chest x-ray and confirming something out of the sputum. Currently, instead of doing the sputum culture and actually like culturing the microorganism and handling it in order to stain it, a lot of healthcare facilities are now just doing tests for the antigens, and they're doing more of a molecular diagnostics or an antigen, surface antigen test. So pneumonia. Pneumonia is an inflammatory condition of the lung in which fluid fills the alveoli. So if we think about the structure of the lungs, so you breathe in, the air goes in through your nose, it goes down your pharynx, larynx, trachea, which has those C-shaped rings of cartilage to open up your windpipe. Then it branches through the primary bronchi to go to your lungs, because you have 2 lungs, so you'll have 2 major branches there. And then those bronchi are going to branch into bronchioles, and they get smaller and smaller and smaller, eventually leading down to alveolar ducts and then alveoli. And the alveoli look like grape-like clusters, and that's where you're going to have a lot of surface area for the exchange of oxygen and carbon dioxide between the air and the blood. So if you've got fluid filling up the spaces where you're supposed to be exchanging gases, you're basically drowning in this inflammatory fluid. That exchange of air doesn't happen properly, so the gases don't exchange properly. So people with pneumonia have difficulty breathing, and they get really tired and weak, and it can kill people. And pneumonia is a major leading cause of death, even in the United States. If we talk about infections that cause death, respiratory infections are the highest type of infection that would actually kill a person. So pneumonia is included in those respiratory infections. It can be caused by a wide variety of different microorganisms. Viral pneumonias are usually milder than bacterial for the same reason as when I was talking about meningitis, how when you have bacteria present, you have the bacteria, but then you also have your own white blood cells, your neutrophils that are coming to the area to clear up the bacterial infection and clear up debris from damaged cells. So now you've got pus accumulating in the area. And in the case of meningitis, that's pus in your central nervous system. Now in the case of pneumonia, that's pus accumulating in your lungs. So it makes a huge mess inside of your respiratory system. So bacterial pneumonias are definitely worse. In addition to being caused by microorganisms, there's some environmental contaminants that could cause pneumonia-like symptoms. You could get chemicals inside of your lungs that's not related to any type of microbial disease, but the chemicals could cause pneumonia. So there's community-acquired and nosocomial pneumonias. So community-acquired, you just are out in the community and you happen to contract pneumonia from somebody or from something. Nosocomial is associated with a healthcare facility. Pneumonia usually begins with upper respiratory tract symptoms, so usually you start with the upper respiratory tract infection, including runny nose and congestion. A lot of times you'll have fever, especially if it's bacterial. And then as the bacterium starts to settle deeper and deeper into the lung tissue, then you're going to have the onset of lung symptoms, which includes chest pain, fever, cough, and discolored sputum, which can lead to death. So this is a picture of the respiratory tract, and then you can see where the alveoli are, and if they're filling up with fluid, you're not going to have gas exchange happening. So some of the most common causes of pneumonia. Strep pneumoniae. This is known as the pneumococcus. It's an alpha hemolytic streptococcus, so it turns green on the plate. It's the most common cause of bacterial pneumonia, and its capsule is its main virulence factor. So on the plate you can see how slimy it looks. That's because that gel-like layer that surrounds the cell. There is a vaccine that's available, the Pneumovax, and this vaccine is especially important in elderly patients. And the hantavirus. So the hantavirus is kind of a sneaky one. This one usually causes sporadic infections, which means you have a few isolated cases here and there, but they are highly fatal. So with the hantavirus, this is spread by the feces of the deer mouse. So this is what the deer mouse looks like. And when these things defecate in barns or around where people live, the people go into the area, and then if you disrupt the feces, so let's say you have a barn and you decided to sweep it up one day and you're sweeping, the sweeping causes the viral particles to aerosolize, and then the person breathes these in, and when you breathe it in, you breathe in enough particles, you end up getting infected. So in 2012, there was an outbreak in Yosemite National Park, and a bunch of people died from this, and they just were staying, camping in the campgrounds there, and they ended up dying from this. In 1993, there was an outbreak in the Four Corners area of the southwest U.S. The reservoir is again the deer mice, and it's transmitted in the feces. Airborne dust carries particles into the respiratory tract. It causes a cytokine storm, so a lot of inflammation happens in the respiratory tract, and people can no longer breathe from this, and they end up dying. This is a sporadic disease, and because of it being sporadic, it takes a little while for doctors to recognize the symptoms and get a proper diagnosis that it's hantavirus. But even with diagnosis, there's not many treatment options for this one. So supportive care and hope for the best with respiratory treatments.